So it's now my pleasure to turn over the microphone to our moderators. And I do want to just let you know that you did receive information with all the bios for all of our speakers today. So we're not going to really give you detailed bios today, but you have that information that you received by email. So again, it's my pleasure to turn the microphone over to Dr. Ann Kinderman, who is Associate Professor of Medicine at the University of California, San Francisco, UCSF, and Kathleen Kerr, who is Partner and Consultant at Transforming Care Partners.
Great, thanks so much, Judy. And it's such a pleasure to see so many familiar names pop into this meeting, and look forward to seeing you all over the next today and tomorrow. So we have really enjoyed looking at these surveys and talking about where things are at with Medi-Cal palliative care. So excited to jump in with that. Next slide, please. So the way that this next hour or so is going to go is I'm going to be talking about the survey responses that we received from provider organizations. We'll have a short time for questions and discussion. So if you have anything that comes to mind, a reflection or a question or thing you want to talk about in that section, please do put that in the chat, and we will have our panelists monitoring that, and we can get into that in the quick conversation after. Kathleen will then be talking about the responses we got from our Medi-Cal plans. And similarly, we'll have a short section for questions and discussion at the end of that section. And then we're going to bring in a mix of people from provider organizations and plans to give us their responses, some initial thoughts, and then we'll have a longer discussion. So please put in chat or make notes for yourself of things that you'd like to talk about. Next slide, please. So just to give you some background on the surveys that we've done, we've actually done this survey. We had one 6 months into 2018 to take the temperature there, but otherwise we've done these surveys around February of every year, starting in 2019, to gauge the first few years of this benefit under Medi-Cal. And our surveys have looked at the structural elements of what's going on, some process and policy issues, outcomes, and then sustainability questions, particularly as we've gotten into later years. This year, we were really pleased to see that despite all of the ongoing difficulties of the pandemic and new policies that plans have had to respond to, staffing shortages, other things, we still got a great number of responses, 20 provider responses and 15 plan responses. And I'm happy to say that the responses that we got really represented a range of organization size and regions of California. So we have a nice mix. And Kathleen and I will be presenting some highlights from these surveys. We're not going to cover all the responses in their entirety, but that will be coming with our post-meeting materials. Next slide, please. So without further ado, I'm going to jump into the survey responses that we got from our palliative care providers. Next slide. So some highlights of the provider organizations that we heard from, that they were all had at least 3 or more years of experience delivering palliative care. So they're pretty used to doing this by now, which makes sense for when SB 1004 came to effect in the beginning of 2018. But most of the people who have been really engaged with us do have more experience and are in a different place than when we first started doing these surveys a couple of years ago. Most of our respondents deliver care in more than one county. So there's experience, I think that's important to highlight, particularly in working with the Medi-Cal population, that may or may not mean that you're actually dealing with different public health systems when you're crossing counties. So that's interesting to see. And there was a balance between the number of organizations working in only one county and organizations that responded that work in 4 or more counties and have different layers of complexity they're dealing with there. We saw that the provider organizations represented a wide range of geographic areas in California. So at least 33 of the 58 California counties were covered by the organizations that responded to the survey. The respondents are serving patients in both Northern and Southern California and in the Central Valley, representing both urban and rural areas. Next slide, please. For our providers, it's very common that they also provide hospice services. Almost 80% of the organizations also deliver hospice services. A significant minority provide home health services. And I was pleased to see that over 10% of our respondents are already engaging with enhanced care management, which we'll be talking a lot more about as the days today and tomorrow go on. And then a smaller number of provider organizations reported having private duty nursing, home-based primary care, hospital to home transition support, or other services. And other services included things like bereavement services, a hospice facility that they are able to send patients to if needed, and actually providing some clothing and other non-medical supplies for patients when needed. Next slide, please. We wanted to know, particularly in the environment that we're in right now, where is care being delivered? We've been asking this consistently, and not surprisingly, the majority of care is being delivered in patient homes. So 95% of organizations say that they see people in patients' homes. But a lot are also providing care in extended care facilities, so nursing facilities, assisted living, and other residential facilities. I was really pleased to see that over half of our respondents say that they're also delivering care in homeless shelters or medical respite facilities. And I really want to applaud that and highlight this as a thing that the Medi-Cal palliative care benefit, I think, has encouraged among palliative care organizations, because that is not the norm for most palliative care organizations to deliver care in those settings. And not surprisingly, given that this is mostly home-based care that's delivered, providing care in acute care hospitals, and less so physician offices and clinics. So our respondents are really mostly representing home-based services, as has been clear. Next slide, please. So most of our respondents, almost everyone, is providing palliative care by video visits, at least in some degree. And this has actually also increased over the last couple of years, even from 2021, when we did this survey reflecting 2020. So people have adopted this more, it seems like, over time. Next, please. So we looking at this in where and how are people using video visits. So you can see in 2019, reflecting 2018 realities, less than half of our provider respondents said that they were delivering video visits with home visits. Then after the pandemic came up, almost 87% said that they were doing home with video visits, and about the same number or proportion in 2021. The thing that is interesting to me is looking at the proportion that are providing no video visits. So it's similar again to last year. So majority of our provider organizations are doing video visits to some extent. Next slide. But the question is now that it's more safe, or it's become more safe to deliver care also in person, what proportion of the visits are being done remotely, either by video or by phone? And what we're seeing is that actually the majority of our provider organizations that responded to the survey are doing remote visits half the time or less. So the vast majority are doing predominantly in-person visits with video or phone visits as a supplement or to do between the in-person visits, with a significant minority who are doing predominantly video visits. Next slide, please. So the question also is, how is care being paid for? So we are, I would say, I think it's been encouraging to see that most of the provider organizations are getting the per member, enrolled member per month case rates, just recognizing that some of the disciplines that are really important to include in palliative care services, like spiritual care, are not billable traditionally. And so it's nice that organizations have that flexibility to be able to deliver care kind of that makes sense for what the patient's needs are in that moment. The thing that's interesting to see for me is that the initial assessment fee was more commonly paid for in 2019 in that gray bar as opposed to now. So there are some components like the initial assessment fee, and then you'll also see a little bit lower down fee for service as an add-on to the case rate, and the incentive for data collection. These are all extra payments that were initially delivered by the plans that are less commonly reported by our palliative care organizations now in 2021. And that some things like incentives for data collection makes sense to me, that initially encouraging data collection at all, but then more incentives for quality, like you can see incentives for utilization outcomes, those are still present in about the same proportion that they were when this benefit started. But there has been some drop off in payment for some of these other components. Next slide, please. So now I want to get into how are provider organizations assessing quality and how are they thinking about improving quality in the next year. Next slide. We asked specifically about external certification for the provider organizations, either through the Joint Commission or through CHAP. And glad to see that the vast majority of organizations that responded to our survey said that they already have certification for one or both of these entities. And an additional 5% said that they were planning to apply. So it's a pretty, nice validating external measure to see that the entities that are certifying people in quality palliative care, the majority of our respondents have that. But interestingly, this year, for the first time, we also asked about whether the provider organizations are requiring certification for different members of their interdisciplinary team. And all of the provider organizations said that they required certification in hospice and palliative medicine for the physicians, but it was much less common that was reported that they required certification for nurses, social workers, and chaplains. And I think that's an interesting thing to think about with what are the reasons for that. And what I would love to hear from provider organizations in the chat or in our discussions coming up around your thoughts about certification requirements for these other disciplines. Next slide, please. We wanted to know also, what metrics are providers assessing? And we found that very high in here was patient or family satisfaction. Almost all are reporting that. You can see also very common to look at advanced care planning metrics and post-completion, and also looking at referrals. And then much less common, which is consistent with previous years, spiritual assessment does not seem to be as common an assessment that is actively tracked. It may be happening, but it is not being tracked or observed. Next, please. And I just wanted to highlight a few of these numbers. So I mentioned I was really pleased to see the patient and family satisfaction responses. And I think the thing I will say here is just that this is not easy to do. It's not easy to do for any particular patient population, but especially in the Medi-Cal population, where it can be hard to track people down. So I'm very curious for the provider organizations that are on in this meeting today, what your experience has been with family satisfaction, what are the challenges and things that you've been able to overcome. And that's something would be great to hear about. Also, I was really pleased to see that 85% of our provider organizations say that they're looking at the proportion of referred patients that actually get palliative care services. And that to me is nice to see, because we've consistently over the years heard from organizations that there's a drop off in the people who are referred to the people who actually enroll, and getting at why that is and looking at that more deeply hopefully yields better information. And then much more, a higher percentage this year said that they're also looking at a functional assessment, which is really interesting to think about predictors of mortality and using that as a metric. Next slide, please. So we asked the organizations about what are the things that are getting in the way of you delivering the best care possible. And we did this on a Likert scale from 1 to 5. And the people who said the most significant issues we're highlighting here. So the most common moderate to significant issues were that there are just not enough referrals, which I think we'll get to in the sustainability section, really speaks to that for provider organizations. And persistently again this year, as has been reported in previous years, that primary and specialty providers are not as willing to introduce or recommend palliative care to their patients. Fairly common, but not as prevalent issues that have come up, that it's hard to recruit or train qualified staff, that referrals come too late. That's a particular highlight, as you'll see later on in sustainability questions as well. But it's also a barrier in just if you don't get to the patients soon enough, then it's hard to make an impact. So delivering quality is obviously harder if you have a lot less time with people. And competing for plan programs that are caring for seriously ill, other seriously ill patients is only about 30% say that's a moderate to significant issue. Next slide, please. Other barriers that were reported in free comments, that there's a lack of adequate community resources, primary care, specialty, and oncology providers are overwhelmed with patient and provider ratio and other things, making it difficult for us to collaborate effectively and provide timely interventions and appointments for interventions. And so this is the provider organization saying they just can't find the time for overwhelmed providers in the community to make those connections and do warm handoffs and things. One respondent said that the lack of population health initiatives directing eligible individuals to qualified programs, so having the plan suggest people who would make sense for these programs, that was a barrier. And patients who have competing priorities who are hard to engage because they're distracted by other things, or they have instability around their housing or their life circumstances that make it harder to engage with them. That's been a persistent theme across the years with the Medi-Cal population. And patients who don't have a primary care provider, that has been hard to coordinate care. And then one person flagged just the new legislation that puts limits on controlled substances for rural patients has been a barrier in the population where pain is a significant problem. Next slide, please. In terms of areas where our provider organizations are hoping to focus on improvement efforts in the next year, this has been a persistent hope to focus on identifying more eligible patients, figuring out how to grow this line of business and serve more people who need it, educating providers and collaborating with the existing plan partners, and engaging new payer partners. I will say that all of these responses are similar. They've been very top priorities in previous years, but I would say they're the prevalence of people saying that they want to engage with this in the next year is increased actually from previous years. So it wasn't up to 90% prevalence, for example, for identifying more eligible patients. And it was really, in my mind, nice to see that all of our respondents said that they were going to do at least one improvement area. There was no one who said they had no plans for improvements in the next year. Next slide, please. So in this last segment of the conversation, I just wanted to highlight sustainability assessments and concerns. Next slide. So the big question, how has volume changed? And compared to the previous year, our provider organization said that about 40% saw a significant to modest increase. About 30% didn't see any change, and 30% saw a modest decrease in their volume. And compared to previous years, so compared to responses in 2021, this curve has shifted a little bit to the right. There were slightly higher proportions in 2021 who said that they saw a modest increase or significant increase. Next slide. The big question we just wanted people to assess, is your program sustainable? And this is a concerning trend, I would say, that more of our provider organizations feel confident that the services that they're delivering, Medi-Cal palliative care, are definitely sustainable. And there's greater uncertainty about whether the services are sustainable over time. And since we are looking broadly at what did all of our respondents say in across the 3 years of surveys, wanted to dig a little bit deeper and look at the people who primarily have given us consistent responses over 3 years. Next slide. So we looked at 13 provider organizations who gave us responses in 2020, 2021, and 2022. And I will say that this suggests a little bit more nuance than that overall trend, that last year, interestingly, as the pandemic was in full swing, there were more of these organizations that said that the services were definitely sustainable and less uncertainty. And between 2020 and 2022, similar responses. So this is, again, an interesting question I would love to hear provider organizations and others' responses on, about your thoughts about sustainability and how the pandemic has affected that. Next slide, please. When we tried to dig in to ask about what are the threats to sustainability, what we noticed the most prevalent things are consistent. So that too few patients are referred, and concerns about compensation being inadequate to cover the scope of services that we provide was a greater concern in the first year of services being delivered, and a little bit slightly less of a concern in subsequent years. But the question I have in terms of it's difficult to find or recruit qualified staff, I wonder whether this increasing trend is a reflection of the great resignment and just overall workforce concerns in the pandemic. Next slide, please. In terms of sustainability threats comments, a consistent theme has been that compensation does not cover the cost of care. That is an ongoing concern that we hear from provider organizations. And that, again, too few patients are referred, and too few referred patients are agreeable to palliative care services. So again, that conversion rate. Next slide. This, I think, was an interesting comment. The reimbursement rates provided from the managed Medi-Cal insurance provider we're contracted with are fair. We've identified there is a large gap in care for Medicare patients, and that the reimbursement rate for programs similar to outpatient palliative care provided by Medicare are not adequate. The reimbursement rates provided by Medicare, for whom a program similar to outpatient palliative care would not allow our organization to provide the level of care we feel patients deserve in a financially sustainable manner. And so I think this speaks to what we highlighted before, that these organizations have multiple lines of business where they're caring for patients who are insured under different plans, and they're noticing the difference between Medicare and Medi-Cal. And so that can sometimes blur. Next slide, please. Just the last comment, which I think is hopeful for the future, that one organization said that They're working with Anthem Medi-Cal, which provides enhanced care management and in lieu of services, which include housing assistance, meal programs, respite, in-home support, among others, which has been a tremendous benefit for our patients. And this, of course, is not unique to Anthem Medi-Cal, that all the plans are going to be engaging with this. And so I hope that the provider organizations will be able to develop these connections, if not providing ECM services themselves. And I know that we have, I've used up a lot of the time. Panel, is there any pressing questions that we have come up with in the chat that we want to discuss?
And no, you've done perfect with the time. I do want to say out loud a comment that Kevin Murphy offered in relation to this issue of certification. And he notes, I would preferentially hire a certified caregiver over a non-certified equal candidate, but 90% of my hire criteria is fit. I can pay for a caregiver to become certified. It's difficult to pay for personality or fit. So it's an interesting, it's very, I love that perspective. It also points perhaps to opportunities to think about paying more for certified staff, or helping to cover the cost, or they pay for the certification, but you give them time to do the training. There's different strategies that have been used around, but it's a really good point that you can change certification status. You can't change who they are and how they fit with the organization.
Mm-hmm. Yeah, so. And I would say there are some palliative care organizations and plans, I'm thinking particularly of Care Oregon, that hire specifically people with training in peer support or kind of trauma-informed care, other things as their priority, who may not have as much serious illness experience, just for that reason, to recognize that this population has unique challenges that you can't find as easily among people who have palliative care training. So I think it's a great point.
Yeah, really interesting implications about proctoring and onboarding time and protocols if you're addressing those issues. So yeah, thank you, Anne. That was amazing. This is one of my favorite days of the year when we get to share the survey results. So really glad to see everybody, and thank you for that. That was super interesting. Next slide, please. So now that Anne's filled us in on what our 20 provider respondents told us in their surveys, we'll talk a little bit about what the 15 plans who responded to the survey were able to share. I would say that response number 15 is a little bit less than we've had in prior years, but completely understandable given what we know you all are going through with preparations for CalAIM and other demands on your time. It's about not quite a 63% response rate, which is still really good compared to most surveys that are distributed. As Anne noted with the provider responses, the 15 plans that responded are really representative of the state. We have folks from in metropolitan areas with high population density. We have folks that provide care in rural areas, in the northern, southern, and central parts of the state. The adult enrollment in these plans, the number of adult enrollees in these Medi-Cal managed care plans ranged from over 1.4 million to less than 25,000. So just as we have a lot of variation in the parts of the state that are being represented, also a lot of variation in the size of the plans that are delivering palliative care. So I think it's really useful to consider the collective experience. Next slide, please. So wanted to start off by looking at, from the plan perspective, this question of enrollment and how that's changed last year versus this year. So how it was described for calendar year 2020 versus how it was described for calendar year 2021. I would say that the enrollment numbers that were reported by the plans who responded ranged from 40 to over 2,100. So we have different size plans and also different levels of success in identifying and engaging and enrolling members. This was a specific question in the survey. How does the number of adult Medi-Cal members who received palliative care in 2021 compared to the number who received palliative care in 2020? Some saw 40%, saw a modest increase, not quite 47%, saw no significant change, about the same, and 13% said, I'm not sure. And we had a fair number of not sures about any question that involved reporting numbers, quantitative data. And I think it was just really difficult for folks to make the time to go look things up. Might say a little bit about how easy that data is to gather, and if there's an opportunity to be able to keep that data a little more easily at hand. Regardless, it looks like from the plan perspective, enrollment was fairly stable. Next slide, please. As Ann said, we've been doing the survey for a while now, so we wanted to take a look and see, well, how did things play out in 2021 versus 2019, which I would consider to be the first full year of operation. Many plans were still getting their policies and programs approved through the first quarter of 2018. Other getting, sort of initial rollout kinks worked out. So 2019 is what I view as sort of the first full operational year of SB 1004. We did have 10 plans that responded with information about their enrollment numbers in both for their experience in 2019 and 2021. And amongst those 10 plans, 9 of them reported that they had an increase in enrollment, and 5 of those 10 plans more than doubled their enrollment 2019 versus 2021. As a group of those 10 plans, which does represent less than half of all the plans in the state, there was a 94% increase in enrollment. So you can see the numbers in 2019, these 10 plans reported enrolling a little more than 2,500 patients. In 2021, that was up to almost 5,000 patients. So as expected and as hoped, and very gratifying to see a nice increase in enrollment over time. Next slide, please. One of the ways that you can increase enrollment is by expanding access. And as we know, the criteria put forth by the Department of Healthcare Services specified minimums. You had to provide SB 1004 to at least individuals with advanced cancer, CHF, COPD, and liver disease. And there were very specific clinical criteria for those conditions. But many plans have elected to expand on those criteria, to expand on access. We had, amongst the 15 plans that responded to the survey, 71% expanded eligibility criteria, not quite 43% by adding other diseases, and an additional not quite 29% who both added additional diseases and relaxed some of the specific clinical criteria associated with the 4 minimum diagnoses. So for example, you don't have to give us a MELD score for liver disease in order to qualify. We don't need to see a specific ejection fraction for the heart failure patients. So relaxing some of those requirements. So we're at a point, and this has been fairly steady for a couple of years, where most of the plans have increased access for their members, which is really great to see. Next slide, please. Amongst those 70% of the plans that added diseases to their minimum eligibility criteria, we wanted to know, well, which diseases are you expanding access to? 61.5% added specific neurodegenerative diseases, so MS, Parkinson's, ALS, et cetera. Not quite 54% added renal disease, 38.5% added AIDS. The same proportion also added access to folks who experienced a CVA or stroke, and then also dementia. So if you're wondering about, should we expand access, these are the conditions that your peers have seen fit to add to their specific eligibility criteria. Next slide, please. The big question is, okay, we know how many folks are being enrolled. How does that compare to the number of folks who would be eligible? And the most telling response to this question to me was the 40% of survey respondents who said they weren't sure. And I think nailing down a denominator is something that would be really useful for many plans. I think for the state, I think it's something that is a little difficult to do because folks have changed eligibility criteria, expanding access. But at a particular plan level, knowing how many folks would be eligible and how many folks you're actually enrolling can really help to clarify the amount of attention and support and enhancement that your palliative care programs need. I think that as palliative care is folded into other initiatives related to CalAIM, in particular population health management, I think folks will have a much better sense of how many folks would qualify and then how many of those folks are actually being enrolled. It's also telling that the majority of our respondents, so more than 50%, believe that they're reaching fewer than 25% of the folks who are eligible. And this is several years in. So I think this points to a huge opportunity to try to identify these folks, engage with them, and get them enrolled in services. Next slide, please. All right, a little bit about the palliative care providers and the contracts. I will say that amongst the 15 plans that responded to the survey, they had between 1 and 11 contracted palliative care providers. The median number was 5, so most plans have experience with multiple palliative care providers, whether or not they were a multi-region plan. Next slide, please. We asked folks, now that we've been doing this for a while, you've had palliative care active for a few years, has the number or composition of your contracted providers changed in the last year? And if so, why? So we had 20% of the respondents who said, hey, we had to add new providers to cover additional areas of our market or to handle an increasing volume. Nobody discontinued a contract with the provider because of low volume. And that makes sense operationally. You might not be using them, but it doesn't mean that you discontinue the contract. One plan reported that they did discontinue a contract with the provider because of quality concerns, which I'm sorry that happened, but I'm also glad that there's been surveillance of quality and making sure that there's a good fit between the provider and what the plan expects. 60% of the plans reported that their network was stable. They didn't add or subtract. They just kept the same folks who they've been working with. I think given sort of the slow rise in enrollment, that makes a lot of sense. Next slide, please. Payment mechanisms from the plan perspective. Anne shared some information about what this looked like from the provider perspective. From the plan perspective, for those who responded to this year's survey, almost 77% are using a per enrolled member per month case rate payment, which has been universally endorsed as the preferred method from amongst providers, and also just seen as the best way to pay for these services, given the large amount of support that's being delivered by individuals who don't traditionally bill for their services. So your chaplains and social workers and nurses, et cetera. A little more than 23% of the respondents are still using fee-for-service only, though I do know that that's changing, and some of those folks are now actually moving in to offering a per enrolled member per month case rate. In terms of other ways that plans are compensating folks for delivering this care, almost 31% are still using that assessment fee, which covers the cost of an initial visit and a comprehensive assessment, and that's paid for prior to enrollment. It's a really important mechanism because you could have a palliative care provider go out, spend a few hours doing a comprehensive assessment, and then discover, you know what, this person either that isn't actually eligible or actually declines enrollment. And it's important to be able to cover the cost of the effort involved in delivering that service, especially since it might lead to triage to some other planned programs, even if not palliative care. In terms of supplemental payments, and these are added on largely to the per enrolled member per month case rate payment, there can be fee for service added on to a case rate payment for some of these folks who just have really high needs and are utilizing services well beyond the expected level. And it's great that that's acknowledged given the incredibly complex needs that many of these enrollees have. And then there's limited use amongst our plan respondents of different types of incentive payments, incentive related to utilization. So for example, no hospitalizations in the prior quarter, incentives related to submitting or collecting data. So for example, the provider collects all of the elements required by PCQN, which is now PCQC. We'll hear from them tomorrow. And then also a limited use of incentives related to preparing advanced care planning documents. So a nice slow and steady increase in the proportion that are using the preferred model, which is per enrolled member per month case rate, limited use of supplemental incentives. Next slide, please. We asked about plan requirements related to in-person versus remote encounters. As Anne described, video visits are part of our reality now in the post or the intra-COVID era. So it raises questions about, well, how much in-person care is preferable when there are no COVID-related restrictions to delivering in-person care? And we saw a fair amount of variation in terms of what the plans require, which may or may not align with their preferences for what the type of care that they want to see delivered to their members. A little more than 20% say that they require that the initial visits be conducted in person. You know what, even if you provide most of the care through video, you got to go do that initial visit in person. Almost 29% said that they require a certain number of visits be done in person So for example, you have to deliver 4 encounters per month, at least one of them needs to be done in person. A small proportion of plans require in-person visits based on specific criteria, either having to do with the member, they've got a lot of needs, we need to make sure that you're going there in person, or other criteria. So for example, if they've been in the hospital, you need to go visit them in person. But 57% of the plans don't have any requirements related to this in their contracts. They leave it up to the providers to decide what makes the most sense. And that's really interesting and something that I'm wondering if that will change over time as video visits become more ingrained in practice and as issues related to COVID hopefully continue to diminish. Next slide, please. Anne talked about the certification prevalence among the provider organizations. In terms of the plans, do they require this? Almost 36% do, and that's been slowly but steadily increasing over the years, a recognition of certification as indicating quality in a certain way. You know that a certain model is in place. You know that there's certain things being tracked. And many plans, so almost 36%, recognize the value of this in assuring quality of care for their members. And we will have a session specifically on certification tomorrow. I know that some plans have been hesitant to go this route just because they worry that there's no certified providers in their area. Like if we require this, what if nobody is certified? Well, I went through this process recently with one plan that was considering adding this, and they contacted the providers that they were already contracted with, and it turns out all of them were already certified. So the prevalence of certification may be higher than what the plans are expecting, and it might be worth thinking about if this is something that you want to add to your contracts. Next slide, please. Outside of certifying the organization, we asked that same question about the plans requiring certification amongst the specific staff, the clinical team that's delivering care to their members. And you'll see that in that far right-hand sort of goldy column, 57% have no requirements about training or certification. But they're a minority do. More than 20% do require that the medical director be certified in hospice and palliative medicine, or have a hospice medical director certification, or have at least 200 hours of palliative care experience. One of those 3 potential criteria. A very small number require certification for nurses, social workers, and chaplains. The other disciplines for which there are specific certifications in palliative care, where they're commonly part of the palliative care team. More than 20% do have requirements related to training. So you don't have to be certified, but they do want to see that the staff have completed specific training so that they know that there's adequate skills and confidence and expertise in delivering palliative care to their members. So quite a bit of variation in practice right now, but it's very nice for me to see that there's at least a few plans that have thought specifically about what they want to know the care team is experienced in and been trained in. Next slide, please. In terms of mandatory reporting by providers, it's really quite variable, where you have a lot of differences in the practice of whether or not you're reporting on timeliness of service, assessment of physical or psychological or spiritual needs, assessment or documentation of goals of care, discharge status. A very small number are asking their providers to supply them with information about responses to satisfaction surveys, and more than a third don't request any information at all from their palliative care providers. So I think there's a lot of variation and a lot of room for reflection on what do we want to hear from people so that we know that timely quality care that's delivering what we consider to be important processes is being delivered. Next slide, please. All right, let's look a little bit at stability, sustainability, and looking forward, that long road, that high stairwell that we all have to climb. Next slide, please. All right, we asked plans about a variety of structures and processes, which we have heard from folks over the years as being indicative of promising practices, if not best practices. And the majority of plans had all of them. I'll just highlight a few where there was a slightly smaller proportion that endorsed having these things. So that second row there, at least once a year, we train plan staff, such as care managers, on palliative care and the features of our palliative care program. 2/3 of folks do. It's considered to be important just because staff turnover, there's a lot of programs, and a refresher about what palliative care is and what we offer to our members can be really helpful for folks who are in a position to orient members to palliative care and potentially facilitate a referral. Another promising practice, we have a dedicated contact person for our palliative care provider organizations to assist them with administrative issues and the needs of specific members. Fewer than 2/3 offer that. It can be really important for these members that have very often time-sensitive needs. The difference in getting them enrolled or some DME out there might be the difference for these folks between going to the ED or being admitted to the hospital or not. We have member-facing materials that describe palliative care and our Medi-Cal palliative care benefit. Only 2/3 have that. And it can be a really important tool for letting members know this is a real thing. This is how it's not hospice. And it's something that could benefit you. Along those same lines, describing your program on a website, on a place in your website that's distinct from where you talk about hospice. Palliative care is not hospice, and it's enormously common for both members and referring providers to confuse the few, and having a distinction on their website of it's not hospice and palliative care, it's palliative care separately, it's hospice. Also, we saw fewer than 2/3 of plans with a standardized process for assessing the quality of care delivered by each palliative care provider organization. You could argue that these programs are mature enough now that that should absolutely be in place everywhere. And 60% of survey respondents said that they have a standing operational or IDT meeting with their palliative care providers, something that can really help with building those relationships and also making sure that members are triaged to the right type of support when they need it. Next slide, please. In terms of the types of issues that plans have analyzed in the past year, 100% said that they've looked at palliative care program impact on fiscal outcomes. That tells me there's really an opportunity to come together and talk about methods and see if we can share promising practices and come up with a standardized approach to assessing that important set of outcomes. A smaller proportion looked at utilization outcomes, though of course that led into the fiscal outcome analysis. Very few, fewer than half, 43%, looked at the impact on member experience of care. I think there's an enormous opportunity there. And tomorrow there will be a session on patient-reported outcomes and some great tools that are now available. And then only 15% looked at impact on clinical outcomes. And you could argue that that's the toughest thing to look at, and that's the data that the plans are least likely to have access to. But it's important to think about, and is there a way for us to do this in a more, to increase the prevalence of that assessment, to make sure that we're taking care of that really important thing, which is that members have optimal symptom control. Next slide, please. In terms of improvement focus areas for 2022, unlike the providers where everybody said they were going to be improving something, more than 20% of the plans said, you know what, I'm not going to be tweaking anything having to do with palliative care this year. Makes a lot of sense given the competing demands with CalAIM. Most folks focused on educating referring providers about the palliative care benefit and palliative care in general. This came up a lot in terms of, we asked folks about the resources or tools that would be helpful to them. Near universal mention of help us with referring providers, help us increase the level of understanding amongst those other folks that are participating in care about what palliative care is and how it can help. Next slide, please. In terms of sustainability assessment, again, this is a number that went down a little bit this year compared to last year and prior years. Fewer than 65% of our respondents said it's definitely sustainable. One plan actually said it's definitely not sustainable. And even now, looking back at 2022, when this program has been around for a while, still almost 29% said we can't tell yet. That may be a volume issue, that may be because of fluctuating environment, but still several years in, folks aren't 100% sure whether this works for them or not. And that's a really interesting finding. Next slide, please. In terms of sustainability concerns, the issue that was most frequently flagged as a moderate or major concern was the low enrollment. 40% of folks flagged that. And that has been consistent year over year over year. Things have been getting better. Enrollment is going up, but that still remains the top concern and the top threat to sustainability and efficacy. Next slide, please. terms of a few comments that people shared, it was really nice to hear about plans that were seeing growth in their program. It's exciting to see our palliative care program evolving, which has allowed more of our members to benefit from program services, also focusing on decreasing utilization of the ED and inpatient admissions. There have been many plans, several plans, that have used the launch of CalAIM as an opportunity to sort of revisit their palliative care programs, to redesign and relaunch. And it's really nice to see that those folks who've invested that effort are seeing an evolving program that's reaching more members and having discernible impact. Next slide, please. Amongst those that are looking to do that work to sort of relaunch palliative care or rebuild their program, there's a lot of noise. There's a lot of competing priorities. As this one plan reported, our launch in earnest of this program has been significantly delayed due to COVID response work and the launch of other priority areas, including CalAIM and dental. There is much opportunity for us to do more in this space. Our biggest challenge currently is limited resources and competing priorities. We heard this a lot, and we understand that CalAIM is both an opportunity to examine palliative care and how it can help with broader CalAIM goals. It's also a competing priority where there's things that have to be done there, and maybe palliative care gets pushed down the priority list a little bit. Next slide, please. And finally, I just wanted to share this one comment, which quite frankly made my day when I read it. We asked folks about how they see palliative care fitting in with CalAIM. And this response, we envision the palliative care program closely collaborating with many CalAIM initiatives while maintaining its unique purpose and services. That to me is exactly right. There's aligned programs in CalAIM, there's new goals with CalAIM. Palliative care can help with those, but it is a distinct benefit, a distinct program, and it has a unique purpose and offers unique services. And seeing it integrated in the broader scope will be terrific. But let's also remember it's there and distinct and deserves attention on its own. And so with that, that ends the summary of the highlights from the plan survey. And any questions that came up that we ought to address now before we go to our reactor panel?
No, I think it's a good opportunity to move right into our reactor panel. And then certainly if people have additional thoughts that are percolating, please put those in the chat. Excellent.
All right. Well, at this point, I'd like to invite our panel, Dr. Jim Cotter, Blanca Martinez from Molina, and Dr. Cotter's from Partnership Health Plan, and Dr. Janine Ellenwood from Snowline. If you could all turn on your video and unmute yourselves. Love to hear some of your reactions to both the provider responses and the plan responses. And again, I'll just remind our panel, you'll need to turn on your cameras and unmute yourself so that we can see you as we go into the next phase. So Dr. Cotter, you made it first with getting your video up. Just a initial, just sort of general response to the data that were presented either from the provider survey or the plan survey.
Well, thank you very much for the survey. I love this survey because it really does help me with monitoring our program. I think, first of all, 95% of programs are offering home-based care, which they should because it's a home-based palliative care program. I really like the 55% doing homeless shelter visits, and I'm always impressed when I see those notes from a doctor or nurse in a homeless shelter doing that work, going where the patients are. On the video visits, it's interesting that in 2019, less than half of programs were doing it. In 2020 and 2021, it's 85 to 87%. That's not just a safety issue. Partnership's always been very high in video visits because we're very rural in our northern counties, but COVID has really taught all of us how to connect with patients differently, and I think video visits are here to stay. I really appreciate the quality slides. The Partnership hasn't changed our quality measures in 4 years, and I was going to do this 2 years ago, but COVID got in the way. So this is actually helpful. We've been setting up meetings with our providers to talk about reasonable and not onerous quality measures that we can use going forward. And this is a good place to start. So we actually have a couple meetings scheduled in the next couple of weeks to talk about that. So that was very helpful. So thank you for that. On sustainability, we see about a 40% drop in hospital admissions in the 6 months after patients are in palliative care. And that is really what supports our program. There are a lot of other increased costs in palliative care. in many different ways, but it's still quite sustainable based on that drop in hospital utilization, and that's very important. And then one last comment on the eligibility. I don't know whether I answered unsure or not, but I actually have no idea how many of our patients should be in palliative care. If it's 1% of our population, it should be 6,000 patients, but it's only 300 plus. So I know that we are just not getting enough people in there. And I've been working with my medical director partners to have them kind of loosen up a little bit on the criteria to get people in. These diagnostic groups, we have 5. We added neurodegenerative, but I have an other category, just other, which is someone who basically meets the general criteria but doesn't fit any of those other things. We have a lot more patients in the other category now than we ever did, because it just allows us to look at the patient and not get stuck on a diagnostic group. So, one last quick thing is we've been using PCQN and now PCQC for monitoring our care. It offers a lot of insights on symptom management, on who's seeing the patient and when and how often. And it takes away a lot of the burden, I think, for providers to be giving us data, because we can monitor that through reporting. So that's been a very big help for us in looking at our quality program. And that's my 2 cents worth. Thank you.
That was, I'll give you $10 for that instead of 2 cents. That was great. I have a lot of follow-up questions from your reactions, but let's keep going with sort of initial reactions while it's still fresh for everybody. Janine, Dr. Ellenwood, as the provider representative on this panel, any initial reflections on what you heard from both the provider and the plan survey?
Oh, thank you, Kathleen. Yeah, wonderful information, wonderful data. Really appreciate that as well. And I concur with basically everything you said. Our program at Snowline in Northern California, we partly fast forwarded because of COVID, are offering video visits. We find though that in the Medi-Cal population, it's been difficult. And what's been most helpful is to have one of our providers in the home utilizing our devices and then bringing in another clinician like the nurse practitioner or spiritual care to join that visit. So we sort of use a home-based and video visit as well too. So you have to be creative, I think, in this population as well too. And as you guys have seen or shared, we're really anxious to see how the CalAIM program will help support the social determinants of health and the psychosocial needs that so many people in the Medi-Cal population have. So we're really interested. Our enrollment has increased slightly. We're really looking to increase more, but we find that when the plan identifies patients, it's been much more successful in getting them enrolled. And so how can we identify patients through claims data, which is the big question here too. So we, talking to the providers has been somewhat fruitful, but just like your information identified as well too. And low enrollment is the sustainability issue too. If we had 100 patients on this program, it would be much more sustainable than our current levels. So great information, and it makes me feel comfortable and happy that we're sort of all in this boat together. So thank you.
We're in this together, whether you like it or not. Yeah, good point. Thank you, Janine.
Well, and to add, I was just going to kind of, go on in, slide right into that. I think for us, we've used a platform called Optum iPro, which I think some of the other health plans are also leveraged. So I'm looking forward to being able to meet with my colleagues and figure out which recipe, if you will, are you using to data mine? What have you found successful? And then for us to be able to share, when we've identified or we've inputted into iPro this these metrics or this is what we have found. So I really look forward to that collaboration. We really, like Dr. Ellenwood indicated, we want to be able to identify more members. And I agree that when our team speaks with them, and then we hand it over, we see more of that success. And then also, I think one of the things that continues to surprise me year after year is the low volume of referrals from our physicians, external, like our network, our specialists. And I think I keep breaking my head over it. Like, what can we do differently to help them? And maybe it's a lack of time or to really take that time to review those members. And in a specific region, what we ended up doing is pulling a list of members that were high risk and had high utilization. And we gave those lists to the actual provider and said, I think these would be appropriate members for you to refer. Can you review? And then we had our palliative care vendor in that specific region reach out. But then that, there wasn't a lot of collaboration because they're busy at the office, right? So, I feel like we've tried networking with like our higher volume medical groups in the MSOs as well. And so, looking forward to seeing, okay, this year, maybe through CalAIM, we'll be able to really kind of work together, identify more members. And we're currently already seeing members who are both in ECM and palliative care, which is great. And so we're making sure that the ECM case manager and the palliative care vendor understand their roles, know how to work, ensure there's no duplication of efforts. So we've got those processes in place, and we look forward to being able to train our ECM providers, our community supports providers, and then even within our palliative care network, we want to ensure that they understand a member can receive community supports and not have ECM. And so, there could be services that the members that we're mutually serving, could benefit from. So this year as well, one of the things that I look forward to doing is sharing the data that we have through our dashboard with our providers. So being able to allow them to see trends over time, utilization trends, inpatient trends, enrollment, average length of time. So that's something that, because of CalAIM, that was put on hold last year, to be quite honest with you, and we're still working really hard with CalAIM and now reprocurement, but it's something that we really look forward to being able to do this year.
Blanca, just to clarify that sharing the data about palliative care enrollment, you said you were going to do that with your primary care providers or with the palliative care vendors, or all?
With our palliative care vendors, or yeah.
It's
I use the word provider, sorry.
Yeah, I appreciate your describing the different strategies you've used to try to elevate referring provider understanding of this and to promote referrals. And Jim, I'm going to ask the same question to you, and you can feel free to say I decline to answer. I'm wondering if there's other things that plans do to incentivize behaviors on the part of specialists or referring providers that have been tried in other clinical focus areas that could be tried in relation to palliative care. And so an obvious example is sort of like a expectation around the proportion of women of a certain age who have a mammogram, or expectation of a certain number of folks with diabetes that have a hemoglobin A1C track. And I'm wondering if there's a correlate to palliative care so that it's communicating to these folks that this is actually important to you, that these people are recognized and referred. Is there a different strategy to use there that may be going one step further? So feel free to say none of your business, but I'm just curious about your reaction to that.
Oh my gosh. No, we have not paid providers to refer to palliative care. I don't know how I feel about that. I know that in my previous life in a managed care plan, it would be self-serving to refer high-cost patients to something that costs less. And so we would never have gone there. But I think in our plan, we just haven't done that. We have focused more on coming up with a list of patients who by claims data look appropriate. I've been working with Resolution Care, one of our providers, to try to make that list more, catch more patients, and it seems to be helping. I think working with hospital discharge planners has been a very big success in most of our areas of identifying patients who are good candidates, but we have not done a reward system for referrals. And I'm not sure that I would want to go there for, I just think it doesn't sit well. I'm not sure I want to read that in the front page of the newspaper.
Fair point.
I think
Yeah.
that's the concern that came up around healthcare reform and advanced care planning conversations. I think the nice thing I would say is that both you and Blanca have highlighted is the attention to quality and the suggestion that these programs are not about cost avoidance, but about improving quality for people who are dealing with really serious illness. Totally understand your optics concerns. And my hope, as selfishly as a palliative care provider, is that that dialogue really focuses in on all the things that we know around enhanced quality and offerings, and just that our patients say when they understand what it is, they would want it for themselves or for a loved one. So.
You know, Steve Panelat from your facility gave a great talk about this new method he had to treat cancer that prolonged survival, high satisfaction, low cost, you know, and it's palliative care. There's no question about that. So.
Yeah, fair enough. I guess part of our challenge is we've been at this for a few years. I think all three of you on the plan side and on the provider side represent what I consider to be, just stellar perspective on this. You believe in it, you want people to get it, you deliver it in the right way. But we're also at a point where there could potentially be thousands of both Molina and partnership members who would benefit. And we're still in the hundreds in terms of enrollment. So I'm wondering if we could, what could we do to, either A, just accept that this will take time. It took hospice 47 years to get to serving half of Medicare decedents, or is there some out of the box thinking, some radical thinking that's needed to get us from a tiny fraction of folks who would benefit to half of the folks who would benefit? All right. Let's see. Anne, do you have any questions that you want to put forward now, or should we go to Kate and Monique to see if there's any in the chat?
I think a few have come up, but I'm curious to hear thoughts from the panel around more of these sort of certification issues and quality, because I think that was one of the things that came up in the survey around making sure that the services that your members are receiving are high quality. And so how do you think about that in terms of certification and data and things that you're asking for?
So as far as certification, in our area, in the southern parts of our region, certification would not be much of an issue, but in the northern areas, it probably would be an issue for providers. We do require experience. We require training. They don't have to necessarily have certification. Many of our providers, though, are hospice, Medicare certified hospices, and they all have the certification. So it's really the more rural areas that we have not done that. But we do have training requirements for all staff, but not for certification. Will that change in the future? I suppose if we have more people doing palliative care, but I think in some of our northern counties, we simply wouldn't have providers.
Jim, do you guys ever do this will be required in 2 years and we'll help you get there sort of perspective, or is it you are or you're not, and it's up to them to work with it?
When the program first started, we did offer educational opportunities for staff, and those still do exist. But I think that providers, just as an example, my wife is a hospice nurse, but she started off as a as a hospital nurse who went to hospice and was trained in hospice, eventually got certification, but she wasn't required to have it at hire. She got it later. And I think that's true for many people doing this work. Is they come in, they like it, they get certified because they want to learn more. We could require more. Again, I'm a little bit worried about our northern counties of basically making it so that they can't do their business. But well, that's a good thing to talk about, I think, with our providers.
Yeah. Janine, I'm curious about your perspective on certification. Do you think it's indicative of something about your organization, and how hard it, you know, just your general effort, benefit, what it means, et cetera?
I'm trying to get my camera figured out here. We are Joint Commissioned certified, and are going through our second survey any day now. And what we do is our nurses often, we hire for heart, and then train our nurses. And so by that, they often don't have either hospice or palliative care experience. They all go through the CAPC training that we have for them. And then we encourage and pay for certification for all of our, all disciplines, social work, nursing, and spiritual care. And we find that by doing that, we have really a solid training and basis. And we, these nurses, we hire, we hire for heart. So they want to do this work. They're excited to do this work, and they're excited to have the opportunity to certify. And we think that it kind of offers our payers and our patients and our families the highest quality of care. And so it's really important for us. We don't demand it, but we highly encourage it and pay for it.
Thank you.
Great. It seems in line with the comments that we heard earlier. And it's terrific to see the other side of it, not just requiring and hiring, but just that gets done, you know, over the course of time. That's highly incentivized and encouraged. Terrific.
Kate and Monique, we've got about 3 minutes left before we hit a break. I wanted to see if there's anything that had come up in the chat that you want to put out for the group to hear about.
This is Monique, and I see that there was a comment actually from Anne, and sort of segueing from Dr. Cotter's comment about patient member lists. And I'm really curious, maybe others can unmute or actually write in the chat how they're approaching rather these patient member lists. We've heard Dr. Cotter talked about using discharge planners, using some claims data, but some other innovative ways, either plans or providers, for identifying that, recognizing as a follow-up comment that folks are really busy out in the community, as they are certainly in the plans. So ways in which that experience has played out for other health plans, using those internal plan members, case managers, utilization review, as well as the hospital discharge planners. Thoughts, you guys?
No, at Molina, one of the things we also have is we've got like champions or subject matter experts supporting our regions. And so these case managers are actually looking at the census to identify also members in case someone didn't refer at the inpatient side, you know, or through transitions of care. And then once we identify someone that would be a candidate and we can't reach them, we're bumping it up against the census every single morning. And so if Susie was on a referral list and she ends up in the hospital, then that flags my team to say, reach out to Susie right away. So, and try to connect her at that point, because some of our members, you know, we are unable to reach, maybe they decline. And if they decline and they're in the hospital, maybe this is an opportunity. They'll change their mind about, getting the service. So those are some of the other things we do. Not that it's allowed us to have hundreds of enrollees, but, some of the things that we're doing, to help us.
And I think you can argue those are people who are landing in the hospital certainly they may have, significant needs that are unmet and could really benefit from palliative care in that moment. And it also addresses the challenge that we've heard over and over again from the provider organizations when they have these lists from the plans that contact information is out of date or they can't connect with people. As you just highlighted, Blanca, that even as the plan reaching out, you haven't been able to reach people in the community, but then when they're in the hospital, you can make contact. So I love that as a strategy, and also in educating your staff, your plan staff who are looking at the utilization lists to think about how do we catch people at different instances in their kind of their career, their disease trajectory.
Yeah, and I think the thing that we would love to see is identifying them way before they hit the hospital. That's like my goal, so that they don't have to go through all those challenges and then have an epiphany of, I would really benefit from support. It's like, let's just not even go there for your own quality of life, but we will all get there, I'm sure. It's just having the patience.
Kathleen,
go ahead, Janine.
We work with providers and trying to help identify patients as well too, and even we have some wonderful champion oncologists and champion primary care, and it's very difficult because they don't necessarily look at what the insurance is. They just know that this patient needs palliative care. And so with the electronic medical records, it seems like it would be fairly easy for them to sort of pull out by insurance and then kind of look through. And I've suggested that, but they don't feel that that's fair. That until palliative care is available to all their patients, they're not sort of going to cherry pick by Medi-Cal or whatever health plan. So I continue to work with them on that, but it is difficult from the provider perspective because they want that care for all of their Medicare and Medi-Cal patients.
Yeah, and it's hard to, it's a difficult perspective to argue with, and is a nice segue into a plug for another session tomorrow. We'll have the folks from CMS and CMMI on to talk about the serious ill care models that they've put in place for Medicare beneficiaries, and thinking about how hopefully we can get to that point where it doesn't matter what insurance you have, that it's available to everybody. I do see that we're at 10:22, which, as I understand it, is now 2 minutes into your allowed break time. So I apologize for stealing those 2 minutes from you. I want to really thank our three panelists, Dr. Cotter, Blanca, and Janine, for coming on and sharing their perceptions. And we'll now take a break. We will reconvene promptly at 10:40 to hear about some innovations that have been tackled by your peer plan and provider, your plan and provider peers. So step away, back here exactly at 10:40 where we'll get going again. Thanks, everyone.